I will discuss now, we will find very much resemblance between the pathogenesis and pathology in the bronchial asthma and what is here named as gastrointestinal asthma. I will first present two cases from our clinic. One case is a male primary school student, 10 years old, living in Zambia, presenting with recurrent severe abdominal pain, nausea, anorexia, vomiting, abdominal distension, edema in both lower limbs, diarrhea or presenting with constipation, and this onset was acute with rapidly progressive course. On examination, we find the child has bowel, moderate ascites, lower limb edema, and the history of allergic urticaria and bronchial asthma was taken. He had been treated empirically in another outpatient clinic by a course of mesalazine, but the condition did worse. The abdominal ultrasound revealed moderate ascites, mild hepatosplenomegaly, CBC showed anemia, leukopenia with relative eosinophilia. Urine and stool analysis and serology revealed no parasitism. Acidic fluid was taken and examined to be translated with predominance of eosinophils. Sigmoidoscope was done and the biopsy revealed non-specific inflammation with white blood cell cellular infiltration, mainly eosinophils more than 30 per high power field. Case number 2, 13 years old female from Addis rural area near Zambia, presented with fever, nausea, vomiting, abdominal pain, and urticaria rash, ascites, and almost the same other clinical picture of this one. The laboratory tests show CBC, iron deficiency anemia, leukocytosis more than 18,000 per cubic millimeter, eosinophils were 40%, urine and stool, no significant detection of ova or any other parasites. We did the indirect tumor elimination titer for Fasciola. We find it high, 1/2048, and we know that this will precede the presence of X in feces by at least 50 days in the diagnosis of Fasciola infection, because the time from the infection to the ova excretion takes about 4 months to a year. Acidic fluid with plenty of eosinophils have been taken, and we give the treatment of Fasciola in the form of melazine and a course of prednisolone, and all the condition improved. These two cases present a case of primary eosinophilic enterocolitis, and case number 2 with a secondary case of eosinophilic gastroenteritis due to parasitic infection, which is Fasciola in the migratory and acute hepatic phase. Eosinophilic digestive diseases are among the spectrum of atopic diseases. They include eosinophilic esophagitis, eosinophilic gastroenteritis, and eosinophilic colitis. Eosinophilic digestive diseases are characterized by eosinophilic inflammation of the gastrointestinal tract in the absence of other secondary causes of eosinophilia. This is as primary, but we also know the secondary causes, and we also named secondary eosinophilic digestive disease. This is the cause why we are naming the disease as asthma, because it is also eosinophilic inflammation of the tissue of the gastrointestinal tract, and this is the very famous Kuhn reaction, which we see here antigen presenting cells like the dendrite cells and any antigen presenting cells in the gastrointestinal tract will present the antigen and process it to the T cells, which will initiate the T helper 2 mechanism, and that the EU vaccine also with interleukin 3 and interleukin 5 and monocyclar stimulating factor will increase the chemotaxis of eosinophils and the recruitment of eosinophils. This will cause the liberation of interleukin 3 and interleukin 5 and increase of the production of the immunoglobulin E also and the urination of mast cells. Eosinophils in particular have very strong mediators like the major basic protein and eosinophilic epithelial proteins, which are very much drastic and scarring and sharing to the tissue, causing the severe inflammation. Over the past few decades, the reported prevalence of allergic diseases has increased dramatically. This has been reported by CDC. The prevalence of asthma in 1990 was only 30%, increased to 7.7% in 2007. Mirroring this rise in allergic disorders has seen an increase in the diagnosis of eosinophilic digestive diseases, about 18-fold rise in the prevalence of eosinophilic esophagitis over 10 years in Australia, and over 35-fold increase between 1994 and 2003 in the United States of America. This has made the problem became much in our attendance, and we have a suspicion now to diagnose the case more than before. Of course, the irritable bowel syndrome versus eosinophilic digestive disease. Irritable bowel syndrome is diagnosis reached by exclusion, where symptoms appear to be due to an increase in sensitivity to the bowel, which results in spasm of bowel muscles, as what happened in bronchial asthma. Here, the condition is not eosinophilic because there is no eosinophilic infiltration in the tissues. The inflammatory bowel disease, also the pathogenesis of eosinophils are not pathognomonic of inflammatory bowel disease, but they present a component of the inflammatory infiltrate active inflammatory bowel disease. Of course, the inflammation here is more neutrophilic than eosinophilic, and that is why, as Dr. Hodgwood said, we have to count the eosinophils in the biopsy tissue, because at least it should be more than 24 or 30 per high power fields. Eosinophilic esophagitis, and I remember that Dr. Hodgwood said that we find the eosinophils in the esophagus. Normally, the histology of the esophagus has no eosinophils. There is no eosinophils in the mucosa, submucosa of the esophagus. That is why when you see there is much eosinophils infiltrating the esophagus, this may link us to the diagnosis of eosinophilic esophagitis, especially when the level exceeds 20 or 24 per hour. Eosinophilic esophagitis is the most commonly recognized eosinophilic digestive disorder. Patients often present with symptoms similar to GERD. However, they are not responsive to anti-reflux therapy, and that is according to Dr. Hodgwood. The treatment here sometimes we resort to surgery because there is no good response to anti-reflux drugs like pantoprazole and other anti-reflux measures. There is emerging data to suggest that the use of acid suppressive medications may predispose, not prevent or treat, to the development of eosinophilic esophagitis. Of course, as we know, in the natural or usual GERD, gastroesophageal disease, the treatment mainly we resort to the suppression of acid by the proton pump inhibitors and H2 receptor antagonists. But here, the use of acid suppressive medication may even aggravate the condition, because, as Dr. Areka said, there is a sort of there is increase of the transport of big molecules of proteins, which is not processed enough to be analgesic. Clinical presentation in childhood: intermittent vomiting, food refusal, abdominal pain, dysphagia because of the spasm in the musculosa, failure to respond to conventional reflux medication, and occasionally esophageal fracture. Of course, this picture can initiate in my mind the sensation of the bronchial asthma, because here the circular folds here, these are particularly the constriction of the circular muscles around the esophagus. This is the inner circular and outer ventricular muscles. There is much spasm. This spasm is like the spasm which happens in the bronchial tissue, and this spasm causes the dysphagia and signs of GERD and the reflux. The diagnosis of endoscopic biopsy, esophageal furrows, the furrows due to longitudinal muscle spasm, and the recircular strictures due to circular muscle spasm. In 1/3 of patients, the esophagus and normal number of zero hits should exceed 25 per high bar. This is circular fold and some white specks here. Eosinophilic gastrointestinal enteritis, the diagnosis of eosinophilic gastroenteritis requires a high degree of clinical suspicion, as we said. Given the relatively non-specific history and physical examination findings, the incidence has been underreported. Most of the cases are usually diagnosed as inflammatory bowel or irritable bowel syndrome. Eosinophilic gastroenteritis should be considered in the differential diagnosis of any patient who presents with abdominal pain or other non-specific GI complaints. Of course, the three layers of the gut can be infiltrated with eosinophilic inflammation, and according to the layer, it may be 10 layer, but according to the layer, the symptoms can appear. For example, the clinical picture of eosinophilic gastrointestinal colitis varies by region and depth affected by inflammatory eosinophilic infiltration. If it affects the mucosa only, then these non-specific complaints like abdominal pain, nausea, vomiting, diarrhea, anemia due to occult blood in the stools, and protein losing enteropathy. If it affects the musculosa, there is gastric outlet and intestinal obstruction and colic abdominal pain. If it affects the subserosa and serosa, the patient with ascites and bloating and higher level of eosinophilia in the ascites. The eosinophilic colitis mucosal infection will present with malabsorption, diarrhea, and protein wasting. In affecting the musculosa, it manifests with intestinal obstruction and chronic thickening. Affecting the serosa will present mainly as ascites with fluid analysis showing majority of cells to be eosinophils. Of course, the condition can affect all the layers. As I presented the first case, the affection was having all the layers with signs of intestinal obstruction and ascites, and even there is protein losing and protein wasting. This is the histology because we have to take the histology, not only rely on the picture in the endoscopy, and more than 20 eosinophils are affected, especially in the esophagus, because the esophagus normally has no eosinophils in the histology. This is series reported in the United States. Eosinophilic digestive, this is the lecture. Differential diagnosis, of course, we exclude secondary causes because secondary causes, like as I mentioned here, of course, the glycura and the angiostoma and fasciola, very notorious. Medication indicated including azathioprine, gemcitabine, enalaprate, and other ACE inhibitors, carbamazepine. Inflammatory bowel disease may be associated with GIT eosinophilic infiltrates, but it is mainly neutrophilic inflammation. Connective tissue disease and other vasculitis can be differential diagnosis. The treatment here is very important because when we say a case of GERD and it does not respond to proton pump inhibitor or H2 receptor antagonist, we usually don't think in corticosteroids to improve this case. But certainly in these cases, systemic corticosteroids in a dosing strategy similar to that used in inflammatory bowel disease has been utilized from 1 to 2 mg per kilogram per day for 8 weeks, followed by gradual taper. Topical corticosteroid treatments like the fluticasone or fluticasone, budesonide can be also utilized by oral, not by inhalation. Sodium chloride have been tried with some success, and ketotifen as mast cell stabilizer and antihistaminic also has been tried with good results. Leukotriene receptor antagonist, which is non-kilocast, shown in some cases able to improve symptoms and provide alternatives to corticosteroids for chronic maintenance therapy. Children with eosinophilic digestive diseases use dosage of non-kilocast ranging from 10 to 40 mg daily. Unlike in bronchial asthma, we start with 5 mg and increase to 10. Here we will start with 10 mg and increase to 40 mg in cases of eosinophilic digestive disorder. Randomized controlled trial evaluating the efficacy of non-kilocast in 30 patients with eosinophilic digestive showed significant symptom improvement in the non-kilocast, 62% versus the placebo 72%. 2 minutes. I will say. Here, empiric elimination diet with removal of 6 most common food allergens like the milk, soybean, egg, wheat, nuts, peanuts, and seafood for 6-week trials. There is 74% improvement on the esophageal biopsy for cases of esophageal. Of course, the elimination diet, empiric elimination diet, is very difficult to do, but it can be resorted to in addition to the corticosteroid and the other molecular and other drugs. Thank you very much.
شكرا دكتور مصطفى.